Okay, I think we'll go ahead and get started. Thanks everyone for taking a few minutes out of your day to review a little information around opioid prescribing and this thing that people refer to as the opioid epidemic. Just as a side note, I was at a meeting last evening with Tulsa County Medical Society, and one of the conversations around legislation that's being discussed in Oklahoma for this coming year is the requirement that all controlled substance be e-prescribed. As you all know, we've really pushed recently to make sure that everyone has the ability to e-prescribe controlled substances through the EMR. This may be a moot point at the end of this year if the state legislature actually enacts regulations requiring all e-prescribing of controlled substances. So I think this is a topic that is going to be an ongoing topic for some time for us. I want to talk again a little bit about some of the issues we've discussed on our first agenda. And if you all recall, we discussed basic information around the opioid epidemic, and that should have been sent out to everyone. If you did not get a copy of the slides or of the recordings, please let me know and I'll get a copy out to you. But today I want to talk a little bit again about risk stratification because it's so important to understand which patients are at risk for abuse, the concept of informed consent and patient education, opioid management and monitoring, overdose management, safeguards around diversion, and some of the treatment options. And I'll talk briefly about treatment options, but primarily I want to focus that on our third part of our discussion in 2 weeks. So going back to pain management, I think it's really important to think about this concept as we are having discussions with our patients around medication. The concept of chronic pain management really is multi-dimensional. It includes the concept of procedural management, doing epidural injections, trigger point blocks, pain management, medications, exercise, physical therapy, TENS units, and then good pain management programs include cognitive behavioral therapy and counseling to manage some of those risks associated with this disorder. And we know that the risk of developing addiction is somewhere between 10 and 20%. So regardless of what your original intentions are, the fact of the matter is that there are some patients who will become addicted regardless. And addiction has its own definition we can talk about later. Also, we always have to frame the concept of pain management, opioid management, in the sense of risk versus harm, or risk versus benefit, harm versus benefit. And I think always discussing the idea of the risk, meaning the development of what they refer to as an opioid-centered lifestyle, where you give a prescription for 30 days, and on the 30th day, the patient's requesting medications. You know, that means that they are on a schedule and they are monitoring that schedule very tightly. The development of tolerance, the development of bad behaviors, and some of those addiction diversion issues. On the positive side, despite the fact that we know there are no real long-term studies looking at management of pain in these patients, we know that in the short term, the medications do a nice job of helping control pain. And primarily thinking about it in terms of how do we address improved function. Taking pain medicines so they can stay in bed is really not the goal of any of our therapies. All of our therapies are targeted at how do we improve level of function while managing pain and setting that standard. I have patients routinely in my office that I have to explain that our goal is not to eliminate pain. Eliminating pain is almost impossible in most patients who have chronic pain syndromes. But minimizing pain to improve functionality is always our long-term goal. I've discussed this last time. but I want to talk a little bit about how we risk stratify our patients for the risk of developing addiction. And again, looking at and asking the question about histories of substance abuse disorder. Now, patients can clearly not disclose this information, but I think it's important we ask it. Any history of alcohol use and nicotine use are red flags that suggest the potential of a behavioral abnormality or addictive personality disorder, and any history of using illicit drugs in the past. And that's where an initial urine drug screen may be useful in some of these patients. Understanding about family history, history of incarceration or legal history for substance abuse, underlying mental health disorders, especially things like bipolar disorder, which are clearly high risk mental health abnormalities for or mental health risk for developing abuse. And then this history of sexual abuse, which may be at times a difficult conversation to have, but is an important one. And then lastly, that person who shows up at your office with a fairly substantial opioid dose and been on that dose for a long time, again, is another risk factor. In NextGen and within EPIC, you'll have similar questionnaires. We do have some tools, and these are not used routinely, but the drug abuse screening tool, or the DAST tool, is a really nice tool that incorporates all of this risk factors into a single questionnaire. And this is a simple tool. If you have a patient who you're concerned about and you would like your staff to screen them, simple a questionnaire of 10 to 20 questions can help narrow down the risk. And this looks like this screen right here. Again, it's asking the exact same questions that we just talked about and concerns around risk. And then when you get a final score, at the bottom you see
This is Dr. Mihalec. We seem to have lost our audio.
We lost audio too at 21st Street.
Okay, sorry about that. I'm afraid I just got disconnected. I'm not sure how that happened. I apologize for that and hope everyone's been patient. I'll just continue where I started from on the drug abuse screening tool. This is something that I think is helpful, and we should use these type of things. One other concept that we're hearing lots about is the idea of informed consent, and I think one of the things that we will be adding to our program will be informed consent in addition to our controlled substance agreement, and the informed consent basically is no different than an informed consent for anyone who would be having a procedure or that it includes risk versus benefits. We understand that within the domain of prescribing controlled substances, there are certain things that we have to include in our conversation with our patients. And as I mentioned before, the risk of addiction and dependence is number one, the most concerning. Potential adverse effects. The discussion around duration of therapy, for many patients, we need to make it clear from the beginning that the duration of therapy is limited. It's not, our goal is not to start them on a medicine and leave them on the medicine forever. Every time we have a new start, it should be considered a trial, and that trial has a fixed beginning and end, and patients need to understand this. We need to talk about the goals of therapy and the fact that urine drug screening will be expected in all patients. We need to have a signed narcotic agreement and disclosure of the fact that we will be checking the PMP on a regular basis so that any evidence doctor means that they will be asked to leave the practice. We also need to discuss the most important risk, which is the risk of death and overdose, and then the potential implications of work-related activities. There are employers who if a patient does not explain or does not reveal to them that they're taking controlled substances, could be fired if a urine drug screen is abnormal. And so when we talk about the side effects, what are they? As many as 1 in 4 people will develop side effects from narcotics. And tolerance is a side effect, dependence is a side effect. Also the concept of increased sensitivity to pain, and as we all know, there are people who are on long-term narcotics who become very sensitive to pain. At that point in time, sometimes the best therapy is to eliminate the narcotics. Then you have the bowel-related complaints, nausea, vomiting, constipation, sleepiness and dizziness, confusion, depression, decreased sex drive, and if you've taken care of patients, men especially with long-term narcotic use, testosterone problems are ongoing for many of them. Here's an example of a consent form for chronic opioid therapy, and as you can see, without going through this whole consent form, it explains all of the potential adverse effects and risks associated with this, and we're in the process of building a form very similar to this to provide to our patients. Okay, I've been told that the slides are not changing, so let me...
Okay. I'm like, what's going on here? They need to knock it off.
And so please have everyone mute your phones. We appreciate that. Okay, well, I apologize. For some reason, my slides aren't showing up. So I'll go ahead and just go through real quickly and outline some of the concepts here. I appreciate everyone being patient. I'm not sure why we're having so many technical problems with the presentation today. I wanted to kind of talk a little bit about using my phrases when prescribing opioids, and I'll send all of this out to everyone in the slide deck. But we have the concept of smart phrases in Epic and my phrases in NextGen. And one thing we'd really like everyone to do when they're personalizing their setup for Epic would be to have a smart phrase that you use when you're prescribing opioids. And that smart phrase could sound something like this. I have discussed risks versus benefits for opioid use. The patient was informed that the side effects of opioids include the following: nausea, appetite loss, constipation, itching, diminished testosterone in men, confusion, sedation, and dependence. Some people develop tolerance, which means that the pain medications have a diminished effect over time. Pain medications can also lead to increased sensitivity to pain over time. I've instructed the patient to store medications in a safe, secure location and not to share medications with others. Do not use alcohol or sedatives with pain medications. That kind of a statement could simply be put in the assessment and plan document when prescribing these medications, which then in a way is a form of consent because that note then can be shared directly with the patient. That My Phrase can be built very easily, and we will have it available to anyone who would like that as they personalize their presentation or personalize their information in Epic. Also, remember special populations of patients, pregnant females or pregnant women are one that we have to be very cautious in terms of medications for pain. And this can become an especially difficult problem for our OB-GYNs. Adolescents, knowing that adolescents can be more influenced by these medications and more likely to abuse these medications. The dentists are having a lot of pressure placed on them right now to provide a much shorter course of medicine for dental care. And in older patients where we should be using a much lower initiating dose of pain medicines than younger. Other red flags that we think about include, from the prescriber perspective, is anytime you have a patient on a chronic long-term opioid who's not having documentation for pain assessment is a problem. So patients at least 1 to 2 times a year need to have an assessment of their pain management, their level of functionality, and their goals so that we have evidence that you've discussed this with the patient. Because if the person is truly setting unreasonable goals, that needs to be addressed. If the patient's level of function has not improved with pain management, then the pain management needs to be backed off. Also, infrequent evaluations, people who have not been seen more than once a year who are on chronic long-term narcotics. High volumes of short-acting narcotics without using long-acting therapy. Patients who are on 8 and 10 Lortab without a long-acting narcotic need to be evaluated. Any combination of benzodiazepine, some or muscle relaxant with a narcotic needs to be dealt with and on a regular basis. Anytime we have morphine equivalent doses over 120 milligrams a day without a pain management evaluation, that's problematic. Avoiding 90-day refills on narcotics is very strongly encouraged. A 90-day refill of narcotics simply encourages patients to more medication on hand if it is necessary. Remember, the morphine equivalent dose is what's the equivalent dose of a medication compared to morphine. And those calculations are easily found. 5 tablets of hydrocodone 10 milligrams is the same as 50 milligrams of morphine a day. And so anytime we see people over about 90 morphine equivalents per day, that's a red flag and a risk for death. Anything over 120 milligrams per day should include a consultation with a pain management specialist. And those calculators are out there on the web, and they're easy to find. If you have a patient who's on multiple medications, it's very easy to identify what their morphine equivalent dose is. When you go to the PMP site, the morphine equivalent dose is calculated for you, and if you have anyone over 90 milligrams a day, a pain management evaluation should be considered. The risk factors for overdose include things like sleep apnea, older age, mental health condition, and the dose of the medication. Any use of alcohol should be strongly discouraged. And discuss with family members signs of opioid overdose, because sleepiness and somnolence can be confused in some patients with non-overdose-related symptoms. If they cannot waken a patient who's on chronic opioids, that should be considered a medical emergency, and those people should not be allowed to lay and wait for them to wake up. That's a call to 911, especially if there's any evidence of shallow breathing, blue lips, pinpoint pupils, those are the kind of things that we have to discuss with family members, because they're going to be the first ones to find patients who are potentially overdose patients. And then the importance of making sure that your patients have access to Narcan nasal spray, or the Narcan auto-injectors. Most of the pharmacies carry these now, and any patient who has a dose over 90 daily equivalents of morphine should have a Narcan nasal spray available, and the families needs to be shown how to use these tools as well, not just to show the patient, but to show the family members. Narcan nasal spray is the easiest. It comes in a 2-pack, and so when you order a pack, you've got 2 doses. And the reason it comes in a 2-pack is because the person may not respond to the first dose, and in that case, the patient can be given a second dose within 2 to 3 minutes after the initial dose was given, and this can be repeated every few minutes until the patient responds. But immediately 911 needs to be instituted, because Narcan has a short half-life, and patients can lapse back into overdose symptoms within 10 to 15 minutes of receiving Narcan. Medication treatment options are something we want to spend a little more time on next meeting, but buprenorphine is the medication that we hear most about. Suboxone is the medication which is a combination of buprenorphine and naloxone, and that is primarily the treatment of choice right now in the United States. There's also a long-acting version of naltrexone, which can be given intramuscularly every month, and we're seeing more and more of this treatment being offered. The problem with these medications is that they're expensive, and it's sometimes difficult to convince patients that this disorder is significant enough that we want to move them from their chronic narcotics to a treatment program. We will be instituting a Suboxone clinic in probably the spring or summer of 2018 to assist patients who we no longer can provide narcotic treatment for, but are willing to provide some sort of oversight in a Suboxone program. So I think that I'm going to leave that where it is today, and I apologize again for some difficulties we've had with the slide set. We'll talk a little bit about pain management conversations at our next webinar next week. And again, I'll send all of the slides out to everyone for review so that you have a better reference of what I was referring to. So I'm going to leave it at that, and wish everyone a great afternoon, and thanks for attending.